But there is a treatment that's been going around, which you've been talking about quite a bit, called Ensride, APS, autologous protein solution. Do you want to kind of give us a breakdown of what it is and a bit of history on it as to how it came about and, how it's been introduced to the UK?
Well, yeah, I mean, Enstride APS is a interesting product because what it brought to the market, which was new, was that it was a single treatment. It was for mild to moderately severe osteoarthritis. And when I first heard about it, I saw data on it giving 2 to 3 year outcomes. And that's interesting to us because a lot of the studies tend to stop for about 12 months. That's usually because they are comparing their outcome to what we usually use as standard of care, which is steroids or other simpler treatments. And so even PRP, the vast majority of data on platelet-rich plasma is out to about 12 months. There are some really good recent studies with much longer data showing good benefits at 2 years and beyond for PRP. But Enstride was a little bit of a game changer because with PRP, the data seems to suggest you need several treatments. You get good result, but it's 1, 2, sometimes 3 treatments. Some occasionally more, but our average regime for osteoarthritis of a moderate nature is about 3 treatments. So that's one every 1 to 2 weeks. The patient has to come back to your clinic 3 times. Powering off. The patient comes back 3 times to clinic.
Yeah, I'll mess around with this. Keep going.
Okay. Patient comes back to clinic on 3 different occasions. So actually, it's so patient comes back to clinic 3 times with PRP, whereas Enstride is a single treatment, and that was obviously of interest to patients. Nobody likes having a needle stuck in their knee.
Yeah.
To have it 3 times obviously can be burdensome, and it means 3 visits in 3 days, and it also means 3 consultations and visits with a surgeon or the treatment provider, whereas Enstride it's 1. Why is Enstride different to PRP? Because actually it's a blood product. We take your blood, we spin it, just like we do with PRP, and we produce a plasma separation with a cell concentrate that we end up with, which we inject. But with platelet-rich plasma, the key cell is the platelet. With Enstride, the reason they call it a protein solution is because actually it's not really cellular. It's acellular. By what I mean by that is there are still the growth factors we're interested in and the cytokines. So those are the chemicals that generate signals and that reduce inflammation, but also are the same chemicals that sometimes are responsible for increasing inflammation. So what we want to do is we want to choose those chemicals that generate more anti-inflammatory. So we want a larger quantity of those. We want a smaller quantity of the pro-inflammatory ones. So we want to change that balance in the joint. And what APS does is it takes a whole melee of cells. It's not just platelets. It has some platelets in it, but it has platelets and it has white cells, or leukocytes, monocytes. And then what it does is it actually breaks down those cells. So what you end up with is the proteins and the growth factors and the cytokine chemicals that generate the anti-inflammatory versions of those. You just end up with the end product. So you end up with the end product rather than the cells, which then have to break down and create an effect. You end up with the end product really in a concentrated form, and that sometimes has the advantage of reducing the pro-inflammatory side of injections, because when you put intact cells in, there is an element where they will go in and they'll sometimes create a pro-inflammatory curve before they generate anti-inflammatory signaling, which happens with the growth factors and the cytokines. Whereas with APS, you've separated out those cytokines and growth factors right at the beginning. The cells are gone, you've just got the soup of the proteins, the anti-inflammatory chemicals, and you pop those into the joint, and so you're taking out to some extent the middleman. We've done that in the machines and the filters and the activation process. So it's a 2-step process. When we're preparing it, it goes into the machine twice, and there's an intermediate step where we activate the cells, break them down. That means so we end up with this solution, the APS solution, and that's it. That's sort of where it primarily differs from plasma, but it is made from blood. It's autologous. So it's your own cells and your own growth factors that we're using to generate the effect. So it's still the chances of having a reaction to it or an immune response to it or a negative response to it are tiny or almost non-existent. I would argue, certainly from an immunogenic response, there's always a risk of any joint injection causing side effects like increased pain or a bit of bleeding or a small risk of infection, but that's exceedingly rare. So that's it. I mean, that's sort of Enstride, and I think it is interesting. I think it's one of the few products out there that has 3-year plus data in outcomes. This year they're publishing 5-year data, so it'll be really exciting to see what that looks like at 5 years. And it is a novel way of using blood plasma, relatively novel compared to PRP, and it's a single treatment. So if we can get rid of somebody's arthritis pain for 3 years with one injection.
Yep. So the last segment or audio segment that we got was Enstride, and you could probably talk about that for days and days and days. It's just the way it kind of works and what it can offer people without them even realizing that it's there is incredible. But another one that you have, and this one's really interesting because we spoke about this the last time, where we spoke about athlete A and how he had it. So we've seen the results, like I've seen the results, but this I think uses gold in your body. It's got like a really gimmicky name, Goldic it's called. Can you tell us a bit about that? And
Yes, well, Goldic is an interesting product. Goldic stands for gold-induced cytokines, so it's gold and then IC, the induced cytokines. So Goldic is the name, and it's obviously that's its market name. And I think the background of it is quite interesting. Gold's been used in medicine for hundreds of years, if not.
Really?
It actually goes back into Egyptian times, so you could potentially say thousands of years. Right down from people saying, well, if you wear it, you get less pain in your joints. So that's something that maybe goes back to Middle Ages and even beyond that.
What did the Egyptians use it for?
Well, they used it in medicine for various things, actually skin conditions, and again wearable. So if you wear it, they felt that it helps you with joint pain, inflammation, infection. So we know they used it as part of their arsenal of medicines. But obviously, you don't know any of their science, if there was any.
Yeah.
So I think Prof. Schneider, who invented Goldic, Uli Schneider in Germany, did a PhD where he actually looked at the influence of gold and what it seemed to do, because it's been around a long time. And even up until the relatively recent past, a few decades ago, gold was being used by rheumatologists in the UK for arthritis. Rheumatologists, yes. So the doctors that treat they treat arthritis, inflammatory arthritis.
Yeah.
So as a surgeon, surgeons tend to chop out arthritis. That's our traditional way of dealing with arthritis. But we tend to predominantly deal with wear and tear arthritis, we classically call it. That's a slight misnomer, so it's the wrong name for it because wear and tear arthritis is what we call osteoarthritis. Everyone tends to call wear and tear arthritis, and that's because it starts off with where the joints rub together. Mm-hmm. That wears the cartilage out over time, but people have this idea in their head that it's a wear and tear over time that creates all the problem. Yeah. What we actually know is that it's actually really a biological disease. What happens is you start with wear, that sets off a biological mechanism where all the inflammatory chemicals in the joint then start to react. The lining of the joint, the synovium, the synovial sites, those cells become abnormal in their function. They then generate these inflammatory molecules. Those inflammatory molecules create what we call a catabolic environment, and that pro-inflammatory catabolic environment actually then deteriorates cartilage. It prevents it from healing and regenerating, and it creates a cascade effect where it generates certain enzymes in that hot soup in the joint. It generates enzymes that break cartilage down, so the cartilage actually accelerates. So it's a biological thing, it's not a mechanical thing. It may start as mechanical.
It can be genetic and
that's right. That's right.
Really in your control.
That's right, absolutely. So there are some people that maybe you could argue are pre-programmed for arthritis potentially, and that's something that we're learning. So I think again, a lot of surgeons still see it as a mechanical problem, but it's a mechanical problem that's combined with a biological problem. It's a biological problem that often supersedes the mechanical problem, not the other way around. Because you could almost argue that if it was a mechanical problem, it's actually easy to fix because you just change the mechanics. Yeah. And there's an element of that, and we do that for young patients, sometimes doing what we call corrective osteotomies or realignment surgery, where we take away deformity or overloading of joints. But Goldic prof sort of thought, well, how does it work? You know, in medicine and rheumatology, we've used this for a number of years. So we did a thesis, he did a PhD thesis on how gold seemed to work, and what he noticed was it was generating an anti-inflammatory effect. But what were the conditions by which it generated those effects?
Yeah.
That's what he wanted to really work out. So what do you have to do to the gold? What does the gold do to the body that creates a dampening of the inflammation? And after a lot of research, he eventually got to a point where he realized that one, you have to keep the blood at normal body temperature, which, you know, sort of 37 degrees.
Yeah.
If you keep it and you line these specialized tubes with gold in the linings, there's no gold that goes into your blood, there's no gold that goes into your body. It sits on the outside of these tubes, and you incubate blood within these specialized goldic tubes for 24 hours.
I see. Okay.
The blood actually creates a sort of plasma shift. There's that incubation process within the gold generates a change in the plasma.
Okay.
You then centrifuge. So again, the spinning method that we spoke about before, you centrifuge that blood down, you take away the cells you don't want, and you have the plasma at the top, which now has these sort of high concentration of plasma proteins in it. Some of them have been measured to be 20 times above your normal levels, so it amplifies them quite significantly to 20.
Is that stuff that's already present in the blood
It is.
to gold, which creates those proteins more effectively?
That's right. Well, it shifts. It creates a plasma shift process where the cells in your blood, and those cells would generate more of something under certain conditions and certain signals.
Yeah.
And so the gold combined with the incubation, combined with the filter process that goes on later, gives you a process. He's developed this process that he's then measured certain proteins, and proteins have quite complicated names. One is called gelselin. Gelselin is actually a very common protein in the body. It's one of the most numerous proteins you have in your body, and some of the other proteins are things like GCSF. That's an abbreviation for a long name called granulocyte colony stimulating factor. And we have GCSF drugs because they're the drugs that we give to patients when they're doing stem cell transplants.
Yeah.
Because what GCSF does is it's a colony stimulating factor. What that means is it's stem cell colonies. It's the natural body's way of making stem cells work.
Yeah.
Or multiply or drive stem cells. We have drug analogues of GCSF that we give to a patient before we will harvest stem cells from them, because it actually doubles or triples their stem cell counts.
Right.
Then when we take their bone marrow, we end up with lots of stem cells we can then use as a stem cell transplant into from the donor to the recipient to cure blood cancers, for instance.
Yeah.
So that process is well established, and this GCSF protein again is 17 to 18 fold above normal levels.
Yeah.
So what we're talking about is we end up with a plasma soup in Goldic that is targeted very specifically towards normalizing inflammation.
Yeah.
It drives your body's inflammatory responses down. It normalizes the immune system responses where they're behaving abnormally. So really quite interesting product, because if it normalizes the cell signals, if it normalizes the inflammatory environment, and if it also normalizes potentially the way your stem cells respond or react and upregulates their activity, you've got quite an interesting product that can potentially generate true regeneration. By true regeneration, we mean when it's healing, it doesn't create scarring. It's the absence of scarring. It will create new tendon tissue from a tendon injury rather than scar tissue.
So it's as if it's been not replaced, but it's regenerated that piece of tissue that's actually been damaged.
That's the interesting part. So we've seen some really interesting biopsy data. We've seen some really interesting MRI scan data where we've seen tendon structure return to normal.
We were just talking about Goldic, and now I just want to make a disclaimer. People, who are hearing about us talk about Goldic, and, obviously Dr. Ansar here is an expert. This doesn't mean that you go start inducing gold into your body. Like, there might be some crazy people out there who...
Yeah, absolutely. Yeah, no. One, it's really expensive. It's really expensive to stick gold into your body, and secondly, it's unlikely to work. It's and as I said, Goldic doesn't involve in putting any gold into your body.
Yeah.
Patients often think that is the case. Actually,
I know that's the case. I think that's what it was.
Yeah, I've had patients saying to me, "I've now got gold in me." I'm like, "No, you haven't.
Yeah.
We didn't put any gold in you." We've used it. We've used it to create a plasma concentration process.
Yeah.
to your blood. So it's gold has changed the properties of your blood. It doesn't, and the plasma in your blood, it doesn't go into you in any way, shape, or form. In fact, it never even contacts the blood.
So essentially, you're not incubating it because it's not in like a warm environment, but
It is.
so you're incubating
We're
it.
incubating. We have
So
an
you put it
incubator.
into a-
we
right,
have a
so-
37-degree incubator.
So it stays regulated at.
Yes.
So
for
you
24
incubate
hours.
it in a tube that's lined with this gold solution,
Yes.
which affects the proteins that are in the blood. Then when you spin it, you have a higher concentration of those good proteins.
We separate them out into the plasma because they come out into the plasma, and then we put the plasma through a filter to get rid of to make sure we don't get any substances we don't want, and then we've got the product.
How many people in the UK do this? Because I assume you'd have to really know what you're doing to be able to get this right.
I mean, like anything, there are tips and tricks and nuances. Yeah, so the more you do it, the better you get. It's like anything in life.
Yeah.
So you're right. I mean, as far as I'm aware, we were one of the first, if not the first, users in the UK.
Yeah.
But that was a strange time because it was around 2019. It was launched in the UK, from memory.
Yeah. During
That's just before COVID, and so we did the first few cases in 2019, early 2020,
Yeah.
just as COVID was appearing. And then we had a fallow period for about 2 years where we almost did nobody because we weren't sure of COVID reactions, and obviously the hospitals were snowed under, a lot of private hospitals closed, so we had a fallow period where we used it almost not at all for 2 years, and then we've restarted, and then and again we've had a significant demand actually post-COVID. And one of the beauties of it is that people have suffered a lot of problems post-COVID.
Yeah. Due to obviously.
Due to
having
COVID. That's right, because everyone knows about long COVID.
Yeah.
Long COVID has been a problem for a lot of patients, and those patients are suffering with. One of our theories behind long COVID is that your immune system responds to COVID.
Yeah.
It may respond to the vaccines in a similar way sometimes, and effectively starts to overfire in response to them, and then it can take quite a long time for that immune system to settle back down to normal.
Yeah.
That's one of the hypotheses. I mean, there seems to be lots of different variations of long COVID.
Yeah.
And I've seen some patients, but we've seen quite a lot of patients where
It's hot.
we've seen quite a few patients where.
No, if you carry on. Sorry, I'm just going to get this off the table.
Yeah, we've seen quite a few patients where if we've injected any foreign bodies or substances into them, they've reacted in an abnormal way.
Yeah.
And this is sometimes people who have had the same injection, for instance, hyaluronic acid, which is a common injection put into skin but also joints. We noticed a significant increase in their body attacking it as a foreign body. And that's because for people who have had COVID, and so the body seems to have reset its immune thermometer at a slightly different level for these patients. And so even when they've recovered and they're not unwell, they've got no temperature, fevers, coughs or anything, this can be months down the line, but they're still feeling a bit tired, lethargic, they've still got some of the effects of long COVID, and it seems to be that some of their immune markers are slightly overfiring still. Those patients who are otherwise completely well, when you inject them with a foreign substance, a non-native substance, they seem to react to it. Their body attacks it.
Yeah.
And
cause them to become very ill.
well, no, not massively ill. It just creates a reaction to the substance you put in.
Right.
So you can create, it can create redness, swelling, pain. And you sometimes have to try and get rid of the substance, which can be challenging, or they have to wait for it to break down, which can take months sometimes. Yeah, and that can be then a few months where they're a bit miserable.
Yeah.
So we've seen those reactions, and what's interesting about Goldic is that it has the potential to sort of normalise your immune response and that's at a systemic level, interestingly. So it potentially has a systemic effect. I know, and this is relatively new data, but I read a paper. One of the things I was interested in Goldic for initially was we at the University of Birmingham have actually been looking at some of the effects of gelsilin, one of the interesting proteins that I mentioned that concentrates up to 20-fold increase in Goldic. What we've realised, we've seen an association with improved outcomes in severely injured patients, and that means burns and trauma patients, if their gelatin level normalizes. So if you can keep it at a normal level, these patients seem to do better. And that seems to suggest that it's protective to organs. And one of the reasons it does that is that we think it generates a normal immune response rather than an aggressive abnormal one. And so that's a really interesting thing for serious illness. And one of the side effects that we've seen with things like Goldic is you inject people with it and they seem to get less hay fever, for instance. And that's actually been recorded quite well, especially with Prof's larger data set in Germany. And there are patients who actually come back for Goldic, he tells me, every year because they get quite severe allergies like pollen allergy, and they'll have Goldic and they get very little symptoms for that year and they have it repeated yearly. And so that's quite interesting. We're not currently using it for that reason in the UK, but when I hopefully get a bit more research done on that space, then it'll be something that we'll be quite interested in. So yeah, I mean, Goldic is really, really interesting. It's quite novel in the UK. There are a few practices now using it. We're probably the dominant practice in the UK from volume of use and experience of using it. And we've got a few clinicians that use it across our group at Pinnacle. But yeah, so again, a really, really interesting product, and I think we're only just touching the tip of the iceberg on how useful it can be in the future. We're only just there.
In terms of research or in terms of how you've just broken it down?
Both. I think the research side of it is only just gathering pace. There's a randomized controlled trial going on for treating patients with long COVID with it, and that's ongoing at the moment. And actually, we'll have some data to report. My understanding is soon, but also other areas.